Welcome everyone to our special session on the 2025 focused update of the 2019 ESC EAS Guidelines for the Management of Dyslipidaemias. It is an honor to have with us today Professor Lale Togozoglu and Professor Janine Reuters van Lennep, two outstanding experts who have contributed immensely to the field. And co-hosts Assistant Professor Fotios, Barkas, Greece, and Assistant Professor Maria Cherska, Ukraine.
Thank you for joining us. Today, we'll focus on the key updates, challenges, and practical applications of these guidelines. So let's start together with Professor Tokozoglu. What's the update on cardiovascular risk estimation and primary prevention?
The new risk stratification system we are recommending with this update is SCORE2 and SCORE2 older persons. They have been updated with contemporary data and have been validated in large populations. The important point here is that they take into account both fatal and non-fatal events, because with the new therapies, we're getting more non-fatal events. So they give us the 10-year risk of fatal plus non-fatal events and use non-HDL instead of total cholesterol, which is also an improvement because of the cardiometabolic risk. We're getting more and more elevations in remnants. Both are used, but for SCORE2 elderly persons, you have to be above the age of 70, and there is competing risk adjustment for those, and this also has been validated. Now, the best risk stratification system is the one that is derived from the population it's used for. Therefore, they have divided Europe into 4 regions, and according to very high risk or low risk, the calibrations are changed. So this is the best we can do today to calculate their 10-year risk.
Why did we abandon age-specific LDL cholesterol cutoffs within SCORE2 and move to category-based thresholds instead?
First of all, we have to keep in mind that this is an update of the 2019 guideline. It's not a new guideline. So when stated otherwise, the old guideline is still valid, and this goes for the whole theme. Now, in 2019, we calculated 10-year risk of fatal events and used category-based thresholds, which we have data for from randomized trials. It was very simple, and it was well understood. Then in the 2021 guideline, there was a new concept of age-specific thresholds. This was for lifetime risk, which may be an advantage for younger people. However, there are no thresholds for lifetime benefits, and we need to take into account duration of treatment, cumulative exposure of risk factors, which makes it difficult to give specific thresholds for those. And since we were updating the 2019, we just used the new risk stratification system, but we kept the goals and thresholds similar. So this is why we don't have lifetime risk. We have 10-year risk, which we have much more data for. But for a younger person, you can also use the lifetime risk.
Professor Reuters van Lennep, what's new on risk modifiers beyond SCORE2 and SCORE2 OP?
Yeah, actually, what we realized is that not all risk factors can be taken up in SCORE2 and SCORE2 OP. So there are also other clinical conditions and demographic conditions, but also biomarkers, which can be used to really, more refining the risk score of an individual, particularly for people who are at moderate risk or actually on the threshold of certain treatment decisions. And we have defined several demographic and clinical conditions which you can use as risk modifiers. For example, if you have a family history of premature cardiovascular disease, or we also know that people from certain ethnicities, such as South Asian people, have an increased risk but also people who have social deprivation or stress. But also, for example, female-specific risk factors, such as having a history of preeclampsia, of other hypertensive disorders of pregnancy, and also some biomarkers, such as now we more and more know about inflammation, so a persistently elevated hsCRP or an elevated Lp(a), of course.
Imaging is increasingly used in everyday clinical practice. Let's say, for example, a 35 years old asymptomatic man with an LDL cholesterol of, let's say, 170 milligram per deciliter or 4.4 millimole per liter undergoes preventive imaging, either a CAC score of 100 or a CCTA showing non-obstructive coronary plaques. What does the focused update advise us to do right now? And what LDL cholesterol target should we aim for?
Yeah, actually, that's very interesting because, of course, your example is a 35-year-old asymptomatic man who has a CAC score of 80, which is really elevated for that age. And also, if you have also already non-obstructive coronary plaques, so that is according to the new update that is documented HCD on imaging. So in that sense, this person might be not a low risk person, which might be before the imaging, but a very high risk person.
You also mentioned to us that social deprivation, stress, depression, or physical inactivity are considered as risk modifiers. How do we really assess them in our clinical practice?
Yeah, that's also an interesting question. And we do not have validated questionnaires or something like that. And also, I think that is in clinical practice, that's also impractical because, I mean, if you see a patient in your patient clinic, you're not going to first have lots of questionnaires. But sometimes it can be quite obvious if there is social deprivation, if it's a homeless person, or if it's a person with like a lot of stress. So I think that you should use these clinical conditions more as flags and something that you take into account. And also that several times it's also those kinds of demographical and clinical conditions are interrelated. So if you have social deprivation, people also have a lot of stress. So in that sense, it's clustered and you can use it, but it's not to make our lives more miserable by introducing a lot of extra questionnaires, etc.
Professor Tokozoglu, what's the update on combination LDL cholesterol lowering strategies?
Now that we have more stringent goals, we're increasingly using combination therapy. And in the guideline, we recommend that if LDL goals are not achieved with maximally tolerated statin therapy, then combination is warranted. And the choice of combination should be based on the amount of LDL lowering we want to achieve, and also patient preference and obviously reimbursement policies. We recommend one or more class of therapeutic agents with proven cardiovascular benefit. So on top of a statin, you can use ezetimibe, bempedoic acid, or a PCSK9 inhibitor. And with the results of the CLEAR Outcomes trial for statin-intolerant patients, bempedoic acid has become a new choice for us, but it can also be added on to statins to get to go.
Do you anticipate a role for triple lipid-lowering therapy, including injectables, in the acute coronary syndrome setting in the near future? And what do you see are the key barriers to such an implementation?
It is possible because acute coronary syndrome is the time when the patient is most vulnerable, and combination therapy will get the patient to go. And we're learning both from imaging trials and also from analysis of the Sweetheart trial that not only getting to goal matters, but in acute coronary syndromes, getting to goal early on also matters. For that reason, in the new guideline update, we are recommending either intensification of therapy if the patient was on therapy, or if the patient was not on therapy, start with either a statin or combination, depending on how far we are from goal. The guidelines have now green light for statin ezetimibe combination, but possibly in the future, if the patient is very far from goal, you can even start a PCSK9 inhibitor according to this guideline update. But in the future, maybe we will try to be more aggressive in the ACS phase. And if the EVOLVE-MI trial turns out to be positive, then start initial triple combination. Of course, there are challenges here because most of the healthcare policymakers are preferring a stepwise approach for reimbursement. So we really have to prove that starting on early on, striking early and strong makes a good difference. Then, of course, the guideline can be updated with triple. And most cardiologists in Europe are in favor of this approach, but applicability will need more trials and more learning and maybe more real-life data to be collected.
Professor Ruders van Leppen, what's new for the treatment of homozygous FH and severe hypertriglyceridemia due to FCS?
Yeah, thank you. I mean, it's very encouraging that even for these rare diseases such as homozygous FH and also FCS, there have been new treatment options for these patients. And to start off with, for patients with homozygous FH, we also recently developed a new EAS consensus statement, but it was after the 2019 guidelines. So first of all, the treatment strategy is according to the 2019 guidelines, especially also for patients with homozygous FH, according to the EAS treatment algorithm there. But what is new and in this focused update is also that in patients whose statins, PCSK9 inhibitors, have little efficacy, especially those who do not have LDL receptor activity, there's a new drug which you can add, and that's inapamab. And that's a monoclonal antibody against HPTL3, and that has shown benefits in the reduction of LDL cholesterol in these patients, and there's now also EMA approval. Now, and then for patients with hypertriglyceridemia due to familial chylomicronemia syndrome, FCS, there's also a new drug which has been approved by the EMA, and that's polyneurosurgeon, and that is an antisense oligonucleotide targeting ApoC3, and that lowers triglycerides. And what was shown in a randomized controlled trial is that polyneurosurgeon lowered triglyceride levels by 77%, but also was associated with a lower risk of pancreatitis. So for those two conditions, we now have new recommendations to use these new drugs.
Professor Tokgozoglu, what are the new messages on LPA testing and interpretation?
So we're getting more and more information on Lp(a), and this has helped change the guideline update. Now, back in 2019, we had recommended universal testing for everyone, and that still holds. So this is not new. we also added that after menopause, women, if they had borderline levels, should also have a second time tested. Otherwise, it's genetically determined and usually once in a lifetime is enough. So this message is not new. In the old guidelines, we had recommended universal testing to catch the very high Lp(a) person whose risk is as high as having untreated familial hypercholesterolemia. But now we have learned that the continuous risk, there's a continuous risk between Lp(a) and cardiovascular events. The risk starts to increase at 30 milligrams per deciliter and becomes clinically relevant after 50 milligrams per deciliter. So if you do not take into consideration Lp(a) levels, you can really underestimate the risk of the patient. For this reason, there is a new recommendation saying that if the Lp(a) is above 50 milligrams per deciliter or 105 millimole per liter, then this should be considered as a risk enhancer and should upgrade the patient's risk. And although we do not have Lp(a) lowering therapies yet, if the patient's Lp(a) is very high, we should concentrate on lowering LDL cholesterol even further and controlling all the other risk factors.
And why was the previous 125 nanomole a liter threshold revised to 105 nanomole a liter? Do you expect this change to have meaningful clinical implications?
This is not a huge change because above 50, the risk starts going up. Now, the reason for these numbers is that for the first time in a large number of patients, 14,000 to be exact, the Copenhagen group looked at Lp(a) levels in the same patients with the DENCA assay, measuring in both molar units and milligrams per deciliter, the same population. And they found a huge correlation between the two, although a simple multiplication factor did not come out. So according to this study, 50 milligrams per deciliter was 105 nanomole per liter. And this is the only huge study testing two assays, the DENCA assay, in two different units in the same patient. So we thought this was the most exact way to go.
And what's the updated stance on icosapent ethyl and omega-3 products?
So now we have changed the recommendations slightly because after the strength study, you know that the negative studies, OMEMI, also came up. So we had to specify our recommendation to high dose icosapent ethyl instead of generally saying omega-3 supplements. That's why we changed specifically to high dose icosapent ethyl to rule out products that contain both EPA and DHA.
And what about fibrates? Have previous recommendations changed?
No, obviously the pimafibrate study was negative, and this has been mentioned in the guideline. But there was no new data since the previous guideline on BISA and fenofibrate. So it still holds that for very high-risk patients, statins are class 1 if the triglycerides are elevated. And as a class 2B, fibrates remain unchanged from the previous recommendation. And of course, as was mentioned, for pancreatitis prevention, we have the volanosorsen, especially in familial chylomicronemia syndrome.
Professor Reuters van Lennep, what changed for primary prevention in special groups of patients, such as those with HIV or cancer?
Yeah, for both those groups, there have been new data, so also new recommendations. And firstly, for people with HIV, now we have a recommendation, which is actually class 1, level B recommendation, that statin therapy is recommended for people primary prevention with HIV were 40 years and higher, irrespective of their estimated cardiovascular risk and LDL-C levels. And that was based on the REPRIEVE trial. And that showed that people with HIV who were used 4 milligrams of pitavastatin that did not interact with their antiviral drugs actually had a lower risk of cardiovascular events, really more than expected. And that also meant that the study was even premature stopped. And that is different from the 2019 guidelines, because also there it was acknowledged that people with HIV had higher risk. But then statins were only recommended in people with HIV with dyslipidemia to achieve the LDL-C goals as defined for high-risk patients. So in that sense, that has changed. And also, there was not really recommendation for statin therapy in patients receiving cancer therapy in the 2019 guidelines. But now, since 2019, there have been 4 randomized trials which assess the cardioprotective roles of statin in patients who have cancer and received anthracycline-based therapy. And these also supported the use of statins to protect from anthracycline-induced cardiotoxicity. So now we also have a new recommendation there that statins should be considered in adult patients at a high or very high risk of developing chemotherapy-related cardiotoxicity, and actually to reduce the risk of anthracycline-induced cardiac dysfunction. So it's another endpoint than most of the other recommendations. But this also aligns with the cardio-oncology guidelines.
And which statins do you avoid with common ART or chemo regimens? And what's your first-line choice?
Yeah, that really depends on which HRT is used in patients. But there is a very good website, www.hivdruginteractions.org, maintained by the University of Liverpool. And there you can enter the HRT, ART, which is used, but also the statins, and then you can see which interaction or possible interaction there is. But having first, we wanted to introduce the table and to really have spelled out all the interactions, but also the ART field was very much in movement. So in that sense, it's better to refer to a website like that and to really look at the statin you like to provide and also the ART, and then decide what would be the best choice. Because, the pre-trial was performed with pitavastatin, but that's not available in many European countries. And also, we really discussed about it, but it's really consider it a class effect.
Thank you very much. And what's a clear message on dietary supplements?
That's a tricky one, because actually dietary supplements are quite difficult. However, what's very important is to first start out with that the 2019 guidelines already made clear that there is a role for healthy dietary habits in lowering atherogenic lipid levels and reducing cardiovascular risk. And that's still the cornerstone. It's a healthy diet. But actually, there have been some evolvements that are important about dietary supplements. And so, for example, the European Parliament and Council prohibited now the marketing of food supplements containing more than 3 milligrams per day of monocholine from red yeast rice. So actually, that was banned. So it's, if you have less than 10 milligrams administered of red yeast rice per day, then it actually has very little effect. We also had the sports trial, and of course it was a short trial, but it compared all kinds of supplements, including fish oil, cinnamon, garlic, turmeric, plant sterols as tablets, and also red yeast rice, and compared it with rosuvastatin 5 milligrams. And there it was really clear that the only compound that really significantly and effectively reduced LDL was rosuvastatin. So actually, we talked about it a lot, and especially because there are so many patients who come now into our clinic with all kinds of supplements that they want to use, including the garlic and the turmeric, etc. We thought it was important to really, then make a statement about these kinds of dietary supplements and vitamins. So actually, our statement now is the dietary supplements for vitamins without documented safety and significant LDL-C lowering efficacy are not recommended to lower the risk of ASCVD. Because actually, you have to realize that none of these compounds, there are endpoint studies. So that's why we came to a class 3 recommendation.
Great, thank you. Professor Togozoglu, one of the key challenges has always been patient access to innovative therapies. What are the main barriers today, and how can healthcare systems overcome them?
The barriers are triple related to the physician, patient themselves, and the healthcare policymakers. The cost, equitable access, and reimbursement are problems, especially with the newer and more expensive therapies. But we need to rethink healthcare policies where value is the outcome and not the price. Hopefully, the price will go down with newer oral therapies, fixed dose combinations, and overall, but it's still going to remain high. And we need guideline driven coverage of most of these agents, maybe even with some public payer inclusion. To be able to convince healthcare policymakers, we need more real world data and new health economic models that show the benefit of this. But if we start very early on with primordial and primary prevention and very healthy lifestyles, hopefully some of these costs would fall down, because now the healthcare systems are more into treatment than prevention. So that is another aspect. But this is not an easy question, and we'll need a lot more data, a lot more education for the physician and the scientists to move forward.
Professor Rutters van Neup, what do you see as the next frontier in dyslipidemia management beyond these guidelines?
Yeah, it's an interesting question. And I think, we have very beautiful guidelines now, but it's also about implementation. And also about really talking to our patients and to increase the adherence. And that's especially in this era with a lot of fake information, especially about lipids, about cholesterol. That's really a challenge. So I think also there that we really, as a scientific and healthcare professional community, that would be our next frontier, is really how to be able to disseminate this guideline, to educate not only our fellow healthcare professionals, but also to reach our patients and to provide reliable information about cholesterol treatment, and to interact with our patients, because now you realize it's very important, because there is so much information on social media, and then science is regarded as just an opinion, and that's very frightening. So I think that is something that we should be aware of. We should get out of our ivory tower and interact with society.
So we are coming to the end of this great podcast. Professor Togozoglu and Professor Rutes van Lennep, thank you both for your insightful perspectives. These updates are crucial not only for the physicians that we are treating dyslipidemias, but also for patients across Europe and globally.
And thank you to our audience for joining us today. Stay tuned for more discussions on the latest in cardiovascular prevention and care.